Hi, and welcome to this 10-minute Tut on an approach to peptic ulcer disease brought to you by the Dr. Coffee podcast. Peptic ulcers are typically a mucosal break of greater than 3 to 5 millimeters with visible depth. They're relatively common when compared to other surgical GIT complaints, and the majority of patients who have peptic ulcers are already over the age of 60. The overall mortality of peptic ulcer disease is 7 to 10%, mostly due to ulcer bleeding, especially in elderly patients with significant comorbidities. About 10 to 15% of peptic ulcer patients will develop hemorrhage. They can occur in the esophagus, stomach, and duodenum, as well as if the patient has a Meckel's diverticulum of the terminal ileum. Gastric ulcers are more likely to develop hemorrhage than duodenal ulcers, but duodenal ulcers are typically more common. Peptic ulcers are usually due to a breakdown in the mucosal defense mechanisms that are associated with increased acid or pepsin secretion. The main etiological risk factors are infection with Helicobacter pylori and the use of non-steroidal anti-inflammatory drugs. H. pylori infects most of the population before they turn age 21, with about 10 to 20% of infected patients then developing an ulcer later on. H. pylori accounts for roughly 90 to 95% of duodenal ulcers and half of all gastric ulcers. NSAID use accounts for most of the rest of ulcer disease not caused by H. pylori. 30% of patients on NSAIDs will get an ulcer, of which 1/5 will have clinically significant ulcers such as pain or bleeding. And this is important to remember because many patients are on long-term NSAIDs, patients with gout, patients with rheumatoid arthritis, and other sources of pain that need control. Other risk factors include cigarette smoking, alcohol ingestion, certain medications, being blood group O, high levels of stress, hyperparathyroidism, and Zollinger-Ellison syndrome. The presentation and features of duodenal and gastric ulcers are slightly different. Duodenal ulcers can occur in slightly younger patients, whereas gastric ulcers, the patients are typically over the age of 50. Duodenal ulcers have a slight male preponderance, whereas gastric ulcers affect males and females equally. In duodenal ulcers, the epigastric pain experienced is usually worse at night when the patient is starved and is relieved by food and antacids. Gastric ulcers, however, are worse with food and can be associated with vomiting and reflux as well as iron deficiency anemia. Duodenal ulcers typically present with periodic pain where they have sharp attacks followed by periods of relief, whereas gastric ulcers tend to have a constant unremitting pain. In general, peptic ulcer disease has a recurrent, well-localized epigastric pain which may radiate to the back. If pain radiates to the shoulder, it might indicate involvement of the diaphragm due to the phrenic nerve. Patients may also complain about hypersalivation in response to reflux. This is known as water brash, or they might tell you that they have reflux of sour gastric juices into the back of their mouth, and this is known as acid brash. Peptic ulcers are classified according to the modified Johnson criteria, where gastric ulcer type 1 occurs in the antrum near the lesser curvature of the stomach and is the most common gastric ulcer. About 55% of patients will have this. Gastric ulcer type 2 is a combined gastric type 1 with a duodenal ulcer and occurs in up to 25% of patients. Gastric ulcer type 3 occurs in the pyloric and prepyloric regions, attacking roughly 15% of patients, and this is usually due to high acid levels. Gastric ulcer type 4 affects the proximal stomach and the cardia, and this is the least common, affecting only 5% of patients. Importantly, this ulcer is in patients with low to normal acid levels. In terms of the pathogenesis of peptic ulcer disease, it is usually due to an imbalance between the mucosal protective mechanisms against acid and other aggressive forces that damage the gastric mucosa. Helicobacter pylori causes a local inflammatory reaction and secretes enzymes that break down the gastric mucosal barrier. It also enhances gastric acid secretion and decreases bicarbonate production. Non-steroidal anti-inflammatory drugs impair mucosal prostaglandin production through non-selective cyclooxygenase inhibition. Prostaglandins are important for mucosal bicarbonates and mucin production and inhibiting gastric acid secretion, as well as maintaining mucosal blood flow. So you can see why non-steroidal anti-inflammatory drugs would cause an imbalance towards the aggressive forces that damage the gastric mucosa rather than the protective mechanisms. So how will your patient with an ulcer present? First of all, they might be asymptomatic and they might be incidentally detected on G-scope and other investigations. Or they might present with symptoms of dyspepsia. This might be ulcer-like with pain in the upper abdomen, or it may be a dysmotility-like dyspepsia with non-painful discomfort in the upper abdomen associated with a sense of fullness, early satiety, bloating, burping, and nausea. They might also complain of an unspecified dyspepsia where they just feel a little bit unsettled. Remember that pain is usually worse with food in a gastric ulcer, while it's relieved by food in a duodenal ulcer. Patients may present with signs and symptoms of a gastrointestinal bleed that is presenting with either hematemesis or Melina stool, or with a bowel perforation. Patients presenting with perforation will have sudden generalized abdominal pain that is aggravated by even the slightest movements. They might have board-like rigidity and guarding present on examination, and this is signs of peritonism. Remember that an erect chest x-ray is the most sensitive investigation for air under the diaphragm and should always be used when investigating for a bowel perforation. So how will you investigate a patient that you think has peptic ulcer disease? The most important and valuable investigation is endoscopy or G-scope. G-scope allows for diagnosis by confirming ulcers, the location of those ulcers, as well as biopsy to rule out malignancy, and biopsy of antral tissue, which is important for testing for H. pylori. G-scope allows for prognostication of bleeding risk according to the Forrest Classification. G-scope is also both diagnostic and therapeutic because it allows for injection with adrenaline or sclerosants, for thermal coagulation, for hemostatic clipping, or for argon plasma coagulation. The Forrest Classification is crucial to remember in peptic ulcer disease. Unlike other classifications, the lower the number, the greater the risk. So a stage 1A or 1B has a far greater rebleeding risk than a stage 3. A Forrest 1A is a spurting arterial bleed with a 60 to 100% chance of rebleeding occurring. A 1B is an oozing bleed with a 50% chance of rebleed. A Forrest 2A is a non-bleeding ulcer with a visible vessel, and rebleeding can occur in 40 to 50% of these patients. Forrest 2B is a peptic ulcer with an adherent clot, and rebleeding can occur in 20 to 30% of these patients. Forrest 2C is a flat spot in an ulcer crater, and Forrest 3 is an ulcer with a clean base. Rebleeding in Forrest 3 occurs in only 3 to 5% of patients. So how do you manage a patient with peptic ulcer disease? First line in management of peptic ulcer disease is conservative management with gastroprotection using the standard dose of a proton pump inhibitor. Proton pump inhibitors promote ulcer healing even if the patient continues to use NSAIDs. The other most important etiological risk factor is H. pylori, and so H. pylori eradication should be used on almost all your peptic ulcer patients. First line is triple therapy with a proton pump inhibitor, amoxicillin, and clarithromycin. However, in penicillin allergic patients, you can substitute amoxicillin with metronidazole. It's necessary to document eradication by either a G-scope with other tests such as urea breath test or stool serology testing. Treatment failure can occur in up to 20% of patients, and this will be when you move your patient from triple to quadruple therapy with colloidal bismuth subcitrate, tetracycline, metronidazole, and a proton pump inhibitor. All patients with peptic ulcers will need to be rescoped in 6 to 8 weeks to document ulcer healing. If the ulcer is still present, it might be necessary to biopsy the ulcer again to exclude the malignancy and also to do antral biopsies to confirm the eradication of H. pylori. In short, biopsy all gastric ulcers and test for Helicobacter pylori. Surgical management is slightly different depending on if the patient has a duodenal or gastric ulcer. Indications for surgery in a duodenal ulcer include persistent bleeding. This is typically because of erosion of the posterior duodenal ulcer into the gastroduodenal artery, or if the patient experiences perforation, and typically perforation occurs with anterior ulcers. If the ulcer is causing gastric outlet obstruction, and in this case the patient usually presents with vomiting of undigested food not long after their meal, they might have a succussion splash, air fluid levels on abdominal x-ray, and the characteristic electrolyte abnormalities of hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. Or if there's failure of medical management, in other words, the ulcer does not heal. Surgeries available for the management of duodenal ulcers include oversewing bleeding vessels, vagotomy with gastric drainage procedures, antrectomy with truncal vagotomy, gastrectomy, and omental patch repairs, which are usually sufficient for small perforated ulcers. For patients with gastric ulcers, the indications for surgery are slightly different. If the patient has a gastric ulcer that fails to heal after 3 months of conservative management, if they have dysplasias or carcinoma on their biopsy, if they have ulcer recurrence, if they have perforation or persistent bleeding. Surgery for gastric ulcer includes oversewing bleeding vessels, gastrectomy. If the patient's gastric ulcer is a pre-pyloric ulcer, then it can be treated similarly to a duodenal ulcer. Remember to rescope your patients in 6 to 8 weeks to make sure that healing has occurred. The complications associated with peptic ulcer disease are multiple and serious in nature. Probably the most important from a surgical point of view would be perforation. Remember that anterior duodenal ulcers perforate and posterior ulcers tend to bleed due to the anatomical position of blood vessels. If you suspect a perforation, do an erect chest x-ray to look for free air under the diaphragm. Patients can also have acute or chronic hemorrhage, and pyloric stenosis can develop, and the patient may present with symptoms of gastric outlet obstruction, which are fullness, dull epigastric pain, projectile vomiting, and on exam you might hear a succussion splash. And you can find out more about an approach to gastric outlet obstruction in a 10-minute tut on this channel. I hope you enjoyed this 10-minute tut on an approach to peptic ulcer disease. If you did, hit the like button and subscribe for more. You can also find us on Instagram at drcoffeeza and listen to the Dr. Coffee podcast on YouTube, Spotify, Apple Podcasts, and Google Podcasts.